I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing.
When you were 9 years old, what were you thinking about doing? Well, I was out playing at the park or on my front lawn, riding bikes, having great afternoon sunsets, and, just enjoying being a kid. But what if you spent your time as a 9 year old thinking about how can I pay for my mom's health care? How can I prevent my mom from dying from a brain tumor? How can I do whatever I can as a 9 year old to get more money? Well, we are very lucky and fortunate to have a healthcare system currently that would not make that something that we have to think about whatsoever because, as we have a publicly funded system, if you need to get care, you don't have to worry about mortgaging your house. But more and more, I've been hearing about this slow progression of privatization. I've seen it in the blogs, I've seen it in the chats, I've seen it on your TikToks and Instagrams of people being like, hey, privatization wouldn't be a bad thing. We should just do it because, it'll create more access. Well, what if I told you in creating access, it actually creates longer and increased wait lists? The evidence is out there that shows that, privatization, one, costs a lot more, and two, doesn't necessarily improve the access. What makes us Canadians is the fact that we have a publicly funded healthcare system. And also, what makes us Canadians is the fact that we make sure that we look after everybody. So, here to talk about privatization and the slow creep that we are seeing within our healthcare system is Cathy MacNeil. Cathy MacNeil is a nurse, is a registered nurse with a degree in health administration and has held certificates in gerontology and emergency room nursing. She's been a registered nurse since 1976, and her healthcare career includes medical surgical nursing, critical care nursing, health administration, nursing supervision, and managing portfolios. She managed a busy ER for 6 years and co managed a long term care facility for 5 years. Currently, she teaches continuing education assistants at a career college and supervises their clinical placements within long term care. Cathy is a proud nurse from Nova Scotia who says she's retired but is actually still doing some pretty dope stuff in nursing. She's also the author of Dying to Be Seen. So, welcome, Cathy, to the show. Thank you so much for coming on the Gritty Nurse podcast, Cathy.
Thank you so much for inviting me. It's my absolute privilege to be here.
Yeah, first and foremost, I always do this with all of my guests. Tell us a little bit about yourself, your background, what got you into nursing, and what are some of the things that's keeping you up today?
Well, I'm currently in my 50th year of working in nursing, but
That's
right at the
amazing.
moment, it seems like a long time. But currently, I teach continuing care assistant students from a local college, and we take them into long term care for their clinical. I do that about 4 times a year. But prior to that, the bulk of my work, I'm very proud to say, was being a staff nurse. And for the most of my career, I was an intensive care staff nurse. Worked in a lot of intensive care units in my city, which is Halifax, Nova Scotia. And then went on, as time ticked on, to get involved in administration. Was approached a couple of times to do some hospital nursing supervisory work, fairly young in my late 30s. And that sort of launched me into later on getting
Right.
into administration, sort of full throttle. I did run a very busy emergency room, inner city emergency room with a catchment area of about 120,000 people. And I ended my career as a nurse manager, one of two nurse managers in a very large long term care facility. So in 2016, I officially retired and then was approached to work with students part time. And I decided to try that just to see if it was an okay thing to do in retirement. And I absolutely love it. So here I am.
Well, I'm glad to say that you enjoy working with students. We need people who want to work with students. And the other piece is, it's funny that you said you're retired, but you're still you're still really working as a nurse. And I feel I have this sense that like nursing doesn't really stop even when you've retired. Because again, we're here, we're having a conversation today, right?
You are exactly right. I know so many people in my own cohort. And even in the school where I am, the director of my program is probably in his late 60s. The other lady that takes students out with me just celebrated her 75th birthday, and we're all
Wow.
nurse
Well, see, this is what I mean, right? Like we say that we're done, but we're never really done,
Never
are we?
quite done.
One of the things that I wanted to talk to you today about, Cathy, is you've been doing some amazing work. And again, I'm surprised you didn't even mention it. You wrote a book and you wrote a really important book. So, again, we're fellow authors as well. And you wrote a book called Dying to Be Seen. What motivated you to write this book?
Well, the motivation really came from, well, those decades of working mainly on the front lines. And the latter part of my career, I was sandwiched perfectly between the staff nurses. I was the manager, so the staff nurses that I worked with every day, my office was in the middle of an emergency department. And then, of course, the directors and the higher administration above me who had policies to maintain and they wanted to implement. And I had the staff nurses saying to me, well, this might not work, or this will never work, or we should try this, but try and remind them this is what we're dealing with. So that position really gave me a lot of insight into some of the problems on the front line. And not only that, the difficulty that frontline clinicians have in articulating their work life to people who are actually making the policy. So at some point in time, halfway through that emergency room experience, which was very tumultuous at times, I thought, if I ever have the time, I'm just going to write a book. And I want the book to relay to the funders, the taxpayers, exactly what is going on the ground.
Yeah.
And so that was like the driving motivation originally behind it.
Yeah, I mean, I think our books are probably similar in the fact that we really wanted people to understand what was happening, a true reflection from a nursing perspective. And I think that, there's so much that's missed in terms of even the media does do a very good job of trying to explain some of the
Absolutely.
work that we actually do, and the ability that we have as nurses to influence the public, not just to say, here's how we're struggling, but to say here's how this can affect the healthcare system. This is how this can affect healthy communities. There's a ripple effect here. And I think that's what your book Dying to Be Seen actually does as well. And there were a lot of concepts that I pulled out of your book that I was like, hey, these are points that we need to touch on. What would you say that the message Dying to Be Seen was about?
Dying to Be Seen really was written for every single Canadian who pays taxes to support the public healthcare system. And secondary to that, I really hope that it would influence policymakers somewhere to have a long, hard look at what has been done and what has not been done in the public system. But
Right.
the main thrust of the book is the worrisome trend to privatize our public healthcare system. To me, it is just an urgent message that Canadians need to hear. And I agree that all around the world, we're seeing more privatization, we're seeing more public private parallel systems. But I have been in this system 50 years and I have seen that when it works, when the chips are down, it works well. And I think to lose it would be a catastrophe for the country.
I agree. I mean, I think one of the things that I noticed was you did do a little bit of a backstory about Medicare in Canada and really how it kind of came to be. And I think many people don't really know about the backstory. So I think it's really important that we understand kind of where we've come from to where we are today. And it's so important that we have this public healthcare system. And my biggest concern is that we are seeing this slow creep of privatization, and it's very concerning to me. And I don't know if people truly realize what's coming down the pipelines and what that can actually mean for them. They're seeing kind of this effect in the States where again they have most of their models are privatized. They have insurance companies which they pay into for their healthcare. But there's this kind of whole effect where I talk about, the lions or the tigers eating their own faces, where they're now seeing some of the effects from, like, whether it's SNAP benefits that are being cut, Medicare being cut, their pensions being some of their pensions even being cut, to seeing how that will actually trickle down and affect their health. But we're not there yet, but it doesn't mean that we can't be there. So we need to talk about some of these issues. One of the things that you talk about in your book is deliberate disintegration. Recently in Alberta, it shows for the privatization of diagnostic services like MRIs and CT scans without a referral. How would you say a move like this, which the government frames as improving choice and increasing access. How would you say that this actually fits into your analysis of deliberate disintegration of our public healthcare system?
Well, it fits in perfectly because if we can back up for a minute and talk about the macro picture. So, no healthcare system in the world exists in a void. Those systems are ensconced in some sort of political system, and the healthcare system in Canada is no different. When I look at what's happening in Alberta, I see it more as a marketing ploy to usher in and to kind of mollify Albertans into thinking, well, if you have enough money, you can go pay for your MRI, your CT scan, your endoscopy. And I think part of the deal that the Premier's swinging, and then if there's something on that scan, then the public system will look after you. Time and time again, if you look at the evidence, and the book has over 460 citations, and the evidence is unambiguous on this, that does not work for the public system. As a matter of fact, when you set up that parallel private-public system, the public system starts to disintegrate even further. So Andrew Longhurst is a researcher out of BC that I follow a lot, and he's done some great work about surgical clinics in Alberta. So he looked at the years 2018 to 2019, pre-pandemic, and 2021 to 2022, and he talks about the rise of these for-profit surgery clinics in Alberta, how they were sort of fast-tracked after the pandemic. And he also then goes on to say, and if you look at Quebec and if you look at Saskatchewan, who are the other two provinces where the for-profit activity is high compared to the rest of the country, if you look at their hip and knee replacement median wait times and their cataract wait times, those three provinces with the most for-profit activity have some of the worst wait times. And there's a multitude of reasons for that.
Right.
Number one, they're staff splitting. So we know there are so many human resources in the system. You and I both know about the nursing shortage across the country. We hear almost weekly about what the physicians are dealing with. And so if you are working in a public hospital down the street and you have 100 nurses and 50 doctors, and a private clinic opens up across the street and they pull half of the docs and half of the nurses because the hours are better, because the clinics are not open on the weekends, they don't work holidays, they're 9 to 5, Monday to Friday, so that entices people to move. In some instances, the salaries are better. Then you've just depleted the public system.
Right.
And you've not only left the public system depleted, but these private clinics seem to cherry pick what surgeries they're going to do. So
Right.
they have a criteria. They take the most stable, the youngest, people who are low risk. So now you have a situation where the public system has all the chronic high risk surgeries and a depletion of staff. Well, we both know what that means, Amie. Longer wait times.
Yep.
More congestion in ERs. So that does not improve the public system. It makes the public system actually worse.
Yeah, I completely agree. These are the things that are not discussed, right? When we hear those arguments for privatization or the arguments to say, "Hey, we need we need to open this clinic to do this." They don't talk about the drain that they're pulling staff from the public system. They don't talk about the fact that, one, it costs the public system much more in dollars, because again, a lot of these private entities are actually funded by public tax dollars. And I think some
Exactly.
people are like, they're shocked when they find out, oh my gosh, that's my money that's paying for it. It's like, yes, it is. And the other piece that you mentioned as well was the fact that they're taking on certain types of clients, right? They want just the stable ones. There's this criteria, and they're leaving the public system to deal with the heavier aspect, the heavier workload. Like you said, we will see that increased wait times. And then what I saw last night when I was looking at some research was, people like to compare to like the UK and Australia. Well, Australia has kind of caught on to the fact that, some of these private entities would do this and said, oh, no, no, no. If we're going to have this type of two-tier system, we're going to have to balance it, and you're going to have to take these types of patients as well. So again, I always look for those arguments when people are like, okay, well, look at what the UK is doing. Look at Australia. They're doing it. Well, yeah, they're doing it. And they're also using other mechanisms to make sure that they're trying to balance it out. But I think that, it's a perfect time to have this conversation because we are seeing those things and we are hearing those types of arguments. And of course, there are counter arguments to say, here's what's actually happening within our public health workforce. And speaking of the public health workforce, I just saw something. Ona talked about it, but I also saw, that there's some concerns about hospital layoffs, right? So in Northern Ontario, they're talking about staff shortages that again will lead to more longer wait times. We just talked a little bit on it, but maybe you could speak to it a little bit more. So how does the outflow of staff due to poor working conditions or the recruitment by these new private clinics directly serve privatization by essentially deliberately crippling the public capacity?
Well, we both know, Amy, that as a nurse or as a physician or physio, whoever we're speaking about, we can't work in two places at one time.
Right.
And so, because of the working conditions, particularly for nurses in the public system, it's not very good right at the moment. And certainly the family physicians are echoing those sentiments as well. A lot of them have had it with the work overload and the hours and unpaid administrative work and more piled on. So here we are as a group of public servants and we're worked to death.
Yeah.
And so when you pull even a couple of us out of there, that workload only gets worse. And when I was an ER manager, I experienced this myself. A private surgical clinic went up behind my emergency room. And the day I took over as the emergency room manager, I had 13 nursing FTEs vacant.
Oh my gosh.
So I stood on my head to recruit and get nurses into that ER. And as I did, when the surgical clinic opened up behind me, several of the girls went there. Now, a lot of them did stay on because I ended up begging them to stay at least part-time and emerge. And they did do that for a while. But at the end of the day, instead of having them 100% of the time, I had them 50% of the time. Right. So the money it takes to recruit nurses and do an in-depth orientation and get them up and running and buddy them with a senior nurse who's also probably run off her feet, and then to lose them, again, just perpetuates what's going on in the public system.
I have these conversations with nurses all the time because, again, you mentioned the fact that, we're understaffed, we're overworked, and then, something pops up to them that seems like a shiny new car. And I have these conversations with nurses to be like, you have to see beyond your nose to see like what it actually is happening and how this again is going to continue to cripple our workforce and to make the public healthcare system much worse than it already is. And it's a challenging conversation. It's the same conversation I have with nurses that work for staffing agencies. I almost have to say to them sometimes, I'm like, I can't blame you, but you have to see how this is actually causing more strife within our system. But how do we talk to nurses? Because again, I'd say nurses are the ones that are primarily listening to this podcast. How do we tell them that, okay, yes, you see this new engine over here, but the workforce needs you over on this end? How do we not just persuade them, but how do we say to them, it's not just the right thing to do, but it's something that is important to do?
Well, I think, like you say, all that's new and shiny, all that glitters is not gold. Right. And I think nurses should understand that if they're in one of these private clinics and for any reason there's a profit downturn, they wouldn't think twice of just saying, you're gone.
Right.
Most nurses within the public system are in unions. They have a little bit of security that way. A lot of these places have no option to pay into a pension. So I know if you're 25 and 30, you're probably not thinking about that. But believe me, when you hit 55, you'll be sorry that you didn't think about that. I guess for me, the thing is, for people who are responsible for the recruitment and retention of nurses, it isn't always about money. It's about support. It's about, in my city here, the tertiary care center, one of the biggest problems, Amy, is there's nowhere for a nurse to park.
Wow.
So I have someone in my family who was a brilliant student, graduated from the University of Toronto as a nurse, went to work at tertiary care here in the city of Halifax, and parking was some obscene amount of money, like $1,700, $1,800 a year. So what nurses do is they leave early. They drive all around city blocks. They look for a place to park. And this particular nurse was parking about 15 or 20 minutes away from the hospital. So for a 12-hour shift, and this is like a typical day in the life of a lot of nurses. So for a typical 12-hour shift, she would get up at 5 o'clock, get ready, drive around city block in the winter, park her car, have a backpack on, walk 15 or 20 minutes to work, get there around, 6:45, work the 12 hours, give report, and in the dead of winter, walk 15 minutes back to often a snow-covered, frozen car, scrape the car, warm the car up, drove home. So her days were from when she did 4 12-hour days. Her days, she told me, were from 5 a.m. till about 8:30 at night on a good day.
Yeah,
Now,
that's
this was a
wild.
young single woman, and she lasted about 3.5 years. And she said, I physically and mentally cannot keep this type of work up. She was young, in great shape. And she said, I'm going home to an empty apartment as a single woman, a small empty apartment. I'm working with women who are 8 months pregnant, who are going home to 2 toddlers, who are going home to 3 teenagers, and after they leave work, they're running to soccer fields. I'm one of the lucky ones, but these women are working like this, and with the workload today, and given the profundity of the job, it's just not sustainable.
No, I couldn't even imagine. I mean, the worst of it for me was I would park. Yes, we had very expensive parking fees, but then yeah, I walk straight into the hospital. Like again, these are the issues that people don't know about. They don't know about, that parking is an issue. That another one, childcare can be an issue, right?
Absolutely.
How many of my nursing colleagues we're scrambling to just try to find someone to watch our children because we were working on nights, or this was my reality. I would work my night shift, my husband would leave to go to work, I would stay up, get my kids ready for school, pack them their lunches, and I'm still not going down until around like 1 o'clock that afternoon, and knowing that I'm going to go back on nights. And that was the cycle. That was how I couldn't do day shifts because I was just like, there's no way. I only could work nights because that's what was sustainable for me. But that's not sustainable. I didn't last very long in that system either. And again, it's just some of these things, we would say that they're small things, but that's not a small thing. There's risk to safety for that nurse who's walking out during all those hours of the
Absolutely.
early morning and night if they have to do that a night shift. There's costs. I mean, she's losing time with her family, right? Time that she could be spending at home doing different things, but it's now spent on the job because it's not like we get paid as we leave the door, right? I mean,
Absolutely.
it'd be nice, but that's not the case. And these are the things that would help retain nurses. Again, I don't know what organizations are really doing in terms of trying to keep us at the bedside. I shouldn't say I don't think they are just not doing a good job. And again, it speaks to the fact of all these nurses that are just saying, we are continuing to lead. There was a study that they just posted out. It was an MEI study that talked about that, like essentially was something along the lines of like by the age of 35 or 40, that we're seeing almost 40% that are just like, no, we're done. We cannot continue with
Absolutely.
doing this type of work. And I urge our politicians, or the people who decide what happens in the hospitals. For example, Ontario Hospital Board Association just said no to staffing ratios, and they had the most ridiculous reasons as to why they said no. And again, it's all a part of how our system continues to be crippled, and it's very, very frustrating.
Yes, and I worked somewhere along the way. I went to a day surgery clinic, probably because the hours were better. And I had about 22 years' experience when I went there. But when I went there, again, staffing was a challenge, and everybody there had way more time in than me, even though I had 22 years in. So I was married to a teacher. He had the summers off. I could never get a summer vacation because the way it was organized was the most senior people got first dibs. And so my husband just could not understand, after almost 25 years of working, why I could not get 1 week in July or August off. So I think these are all the things that the public really don't realize. Vacation inaccessibility, parking, the insurmountable amount of work. And, we have accreditation come in, we have to abide by those standards. We have the hospital, their own policies that we work in, we have all those standards. And it just seems that the expectations get higher and higher, and we're expected to make, a lot more bricks with less straw, so to speak.
No, you're right, and I think that we could talk about the whole vacationing and like that's like
Yeah,
a
I'm
whole
sure
other
there are many nurses out there now shaking their head, yes.
that's like a whole other story. It's like we can't hold seniority over people's heads to say that this person can't take this week off, or like this person can't go have their wedding in the summer because they're not senior enough. Like, don't get me started.
Yes, yeah.
And then the other piece of like accreditation, that's also another frustrating piece for me, right? Again, the whole point or how it's supposed to be designed is that they're ensuring that hospitals are doing what they're mandated to do in terms of, keeping people healthy, making sure that they have policies and things in place. And again, they're front loading more and more, but not necessarily again providing us with more and more. So I would say to these accreditation folks, maybe we should be looking at things like staffing ratios, safe staffing ratios, having stronger language to say,
Workload.
yeah, we need to change the workload. How can we say that this hospital is accredited when we know that there's all these different challenges? Don't get me started because I could
Well, and I know, and
go.
one of the things the accreditors say is they want facilities to be safe. Well, how on earth can they be safe if this is how nurses are working?
It never made sense to me, right? I'm not gonna go too hard on this, but I worked in quality improvement, and it was like oh, they're coming. Here's what we're going to do. We slap this, this makeup on the
Absolutely.
pig, right? They leave and we go right back to exactly ground zero where we have
The way it
barely
was
changed
before they
anything.
walked in.
Essentially, yeah.
Yeah.
It's like we haven't really done anything. We've changed the dates on policies, but we haven't changed our practices or
Well,
changed the way that we can operate so nurses can be safe and that we can deliver safe care.
Well, we had a prime example of exactly what you're speaking about here in Halifax during the pandemic. We have one of the largest long-term care facilities east of Montreal in our city. And just before the pandemic, they were given this super accreditation, basically with commendation, large plaque on the wall. And during the pandemic, they became the epicenter of the pandemic in Halifax. 53 people died. It was a complete disaster. There's now a class action lawsuit by families. But not too long before that happened, if you walk into that facility, and I've seen it, there's this huge accreditation plaque
Of
with the
course.
highest accreditation that they could possibly achieve. But translating that to reality on the ground, none of that worked.
Yeah, I don't understand how like it's kind of like I guess the Joint Commission in the United States of America where it's just like, "Oh, we really want to have the sticker." The sticker means more than the actual work that goes into getting that sticker,
Absolutely.
which is very disappointing. And again, I think that there should be even oversight over those people who come into our organization to say that they're doing things. I've always said that we should attach funding goals to actual patient outcomes. Maybe we would actually see some real change in hospital systems if we actually did that.
Absolutely.
I want to talk a little bit about the role of the federal government. So we've touched on some of the work that happens with some of the things that we see in relation to privatization in hospitals, how it affects the workforce, how, how it affects patients and families. But we need to find those solutions, right? With the provincial governments introducing policies that may violate principles of the Canada Health Act, how effectively is the federal government using its funding and regulatory power to enforce the CHA and to prevent the slow, steady infusion of privatization? I would say that, we saw the budget. I always think that there should be strings attached, but I never really see them. What are your thoughts?
I couldn't agree more. I think that we have a very unique system in Canada. So we have this federal government, and within our country, the provision of healthcare services constitutionally falls to the province and territories.
Right.
And of course, we have the Canada Health Act, which is like the legislative arm of the federal government that says to the province and territories, this is how you must conduct your provision of healthcare services. And that's all great. But more and more, we see workarounds within the
Yes.
provinces of trying to usher in these private clinics and private surgery clinics. And even some of the private medical clinics, how they get around it is they're not exactly using user fees. What they have come to decide is that if you join this private medical clinic, then you sign on like a gym membership. So it's a membership fee. And that's how they skirt around the Canada Health Act. I really do think the federal government could do a lot more with that. But it seems at the moment they're just accepting a lot of that. The
Yeah.
other thing I write about in the book is we constantly have this fiscal food fight between the feds and the provinces and
Right.
territories. So, they hand over billions of dollars. There doesn't seem to be a lot of strings attached. And then when you look at what some of the provincial governments are doing with a pot of money, I mean, you just have to shrug your shoulders and you have to laugh. They are receiving these funds and they're really not doing anything to improve a lot of their own healthcare systems provincially and territorially. So that's an issue. People have asked, should those funds, the transfer funds, come with strings? And I'm at the point now where I'm saying yes, they should. I mean, if you were funding your kid to go to college and you were handing them over a whole bunch of money and saying, hope you're doing well, hope you're going to university, and you had no idea that, he or she was downtown partying or had never gone to a class in a month, I mean, that would not be a good thing. And I see the federal and provincial relationship much like that.
I completely agree with you. I love that analogy too. I think to myself, it's like, all right, so yes, I'm spending all this money, I'm expecting to see change, but when I'm not going to measure it, I'm not going to say here's some metrics to make sure that I can see that there's some change in the system. And two, I'm just not just going to keep giving money. It's like, oh, you come back and you have no degree, no diploma, nothing to show me. It makes no sense, right? And I think that I know that's like, okay, province should be able to do whatever they want to do with the funding. Well, if we're seeing that the system's not working the way it should be, then we need to attach some form of metrics and we need to collect data. I don't understand why we don't have, how do we say that we're improving if we don't have a benchmark to measure that we're actually improving?
Absolutely.
It makes no sense. Same with like nursing and staffing ratios, or not staffing ratios, but like nursing workforce. We actually don't even know how many folks are actually within the workforce. We have the numbers of people who are registered, but not necessarily who's working and where they're working. So it just begs the question, like, are we really trying to make change here? I know one of my gripes right now is healthcare is not even on like the federal government's like top 10
Radar.
priorities.
Yeah.
And that's concerning to me because it's just like, okay, fine, economics, war, tariffs, all those things are important. But if we don't have a healthy community, then what do we really have? It's very concerning for me. You did mention defrauding. I think we kind of touched on it, talking about like defrauding and the profit motives that we've seen time and time again. And I know you've actually in your book talked about a little bit of the US comparison. So your book warns of sliding into a cruel, profit-driven system that bedevils their neighbors to the south. Beyond the obvious, right? What are some of the most significant yet overlooked negative outcomes that we're starting to see in our system right now?
So, well, we see these parallel private clinics and private diagnostic centers being set up. And the more for profit activity that starts to flourish within our Canadian jurisdictions, you'll see more of a deterioration in the public system. So that's really worrisome. And I think if people would just take time to look at the evidence of what we've already done with the for-profit clinics, they would see that the narrative that's out there, let's just open up and all the people with money can go here and that takes them off the public list, problem solved. And that is, a specious argument. It looks good, face value. It might even sound okay. But when you look at the evidence around this is unambiguous. So in 2015, I think it was, Saskatchewan had an MRI wait list of about 5,003 people. And in 2016, the provincial government in Saskatchewan capitulated and said, okay, we're going to allow private MRI clinics to come into our province. And the deal we're going to strike is for every private MRI they do, the company has to take one person off the public list. So it's a 1-for-1.
Right.
4 or 5 years later, the waiting list for MRIs in Saskatchewan was over 10,000. It didn't help a thing. And part of the reason was because the clinic, who had promised to do the 1-for-1 within a 2-week period. So the deal was, we will do a private, somebody pays, and we'll pluck somebody off the public system, and we'll do that within 2 weeks. None of that happened. And none of it happened because the people in the public system, the bureaucrats in the public system, didn't really have anybody overseeing that, which then begs the question, if you're going to monitor all this activity, are you not setting up a whole new bureaucracy? Who's going to make sure it's 1-to-1? Who's going to make sure it was done within 14 days? Well, nobody did, and the list actually got worse.
Yeah.
And if you're going to create another bureaucracy to manage the private clinic, then there's more tax dollars. It would be easier just to open the hospitals, run the MRI clinics even after hours, run them on weekends, holidays, pay whatever. It would be cheaper in the long run and go through the list.
Yeah, no, I believe that's actually happened in Quebec as well. I think I remember seeing something just recently saying that the wait times have exploded in Quebec for the same
Yes.
thing. And they even have, I think, more privatization in some areas in Quebec, particularly around primary care. So it's just the oversight piece, Cathy, is a disaster. We don't have accountability in healthcare. We don't have that. And that's what I'd say probably was one of the biggest challenges. We see all these different things that are happening, and everyone can shrug their shoulders and just say, oh, well, I don't know whose job that is, or that's not my job, or I don't know who's looking into that. How can we say that we have a system that's efficient or that works if we don't know who's doing what? And everyone at the end of the day can be like, well, it wasn't my job and I didn't really have oversight in that area. I think people need to be fired. I am dead serious. Like, we have a chief medical officer of health. I don't think I've ever I don't think I've heard from him since like 2021. Like, it's just, what are these folks doing if they're not actually seeking and seeing that there is accountability and that we're improving healthcare outcomes for, all of Canada? It doesn't make any sense to me. So one of the things that I'd say is, yeah, we need to put pressure on our governments, make sure that we're seeing more accountability. I don't know how to get that, but I think that, again, through having more conversations and maybe choosing and selecting leaders, I think, again, some of the way that we select leaders into these roles are questionable as well. But also just, maybe one of the things I've said is, like, nurses have a lot of power if we really think about the way that we vote. Police unions and
Absolutely.
firefighters, they have no problem saying, okay, Doug Ford or whoever the leader is in charge, if you don't put this X in place, then maybe we just won't vote in accordance. I think nurses, if we had similar collectivity, I should say, that maybe we can actually start really seeing change and saying, here's how we might vote if you don't make these types of changes, right?
Absolutely.
I think the other thing that you touched on that I think is important when we're talking about the US and seeing some of this privatization and seeing that, some folks, the folks that can afford to pay, are the ones that are using these private systems. We don't talk about the equity that we will lose, or the patient outcomes that will be different when we're seeing that the access isn't equal, or that the way that care is being delivered is unequal. And I think that speaks again to, Tommy Douglas, the Canada Health Act, that it shouldn't be that it's not about whether you're able to pay. It's about how equal access and how everybody who comes into the service is going to get the same care, and that care will be delivered based on, symptoms and outcomes and things like that. And I think that we move towards this less equity based mode of healthcare, we're going to see some of those devastating effects that we saw during the pandemic, where we see those pockets, whether it's an area code, or whether it's your race or your ethnicity, or whether it's, you don't have enough income. We see that those folks tend to have the worst healthcare outcomes. And that's also what I'm very afraid of. And people don't understand how that can transform and change our healthcare system as well.
Well, and I think too, Amie, if people would just take a couple of minutes to do the research and look at the data, everything you have just said is backed up by pages and pages of data. So you look at the US, it is an outlier. They're using about 18% of their GDP to fund their healthcare system. And remember, their GDP is galloping towards $30 trillion. That's an obscene amount of money. So you say,
Right.
what are they getting for that? Their neonatal, maternal, mortality rates are terrible compared to other countries, their cohort countries. They have the most expensive healthcare system in terms of their what they use for their GDP. They have 24 million people approximately totally uninsured. They have this burgeoning category, very worrisome category of patients, about 64 million, who are underinsured. So what that means is that people are taking out these health insurance policies and they have these massive deductibles. Some of them are $7,000, some of them are $13,000 that have to be paid before the policy activates. So, and if you had one major issue, let's say you needed a quadruple bypass, you had a bad stroke, that despite paying this insurance, despite carrying these huge deductibles and premiums, it wouldn't come close to covering what you would need to recuperate in that system. So there are so many issues with that system: uninsured, underinsured. There are a couple of million kids that are uninsured. There are studies to show, and I think one of the best ones I used in the book was they say about 45,000 people a year, every single year in the US die. They just vanish because they do not have access to health care. So at the time I was writing the book, I noted that the population of the Northwest Territories was about 45,000. So the analogy I used was picture Canada taking the entire population of the Northwest Territories, and at the end of every year, all those people vanish. And then that keeps happening over and over again because they do not have access to health care. So somebody home who's uninsured wakes up with, crushing chest pain. They lay in bed and think, hopefully it's just indigestion. And it's not, so those people just vanish. They're not just numbers on a page. These are families. These are people with futures. And for the pro-capitalist people, you can say, well, these are people who would have paid taxes, who would have been productive. So the system is a complete and utter disaster.
Yeah, and we don't want to get there, right?
And we do not want to go there.
I think people think that, we can't get there. I think this is what I say to folks. It's like, when we were talking about Roe v. Wade in the States, and we were talking about these various different laws and things that now have been overturned, we never thought we could have got there. But again, my warning and my caution, and it's not fear mongering at this point because we have the evidence there, is to say we need to wake up and ensure that this doesn't happen here, because we can move to a model where we have a two-tiered system. And I think people would have no idea. We don't know what it's like to have a line by line item like, oh my God, Kleenex is what I'm paying for. I don't know what it's like to have to mortgage my house because my child is sick. Like, we don't want to get to a situation where that is what is happening. And I can tell you from some of the posts I've seen from Alberta to Saskatchewan to Ontario, people really don't truly understand that if we go down this route, that is a part of the route that we would be taking as well. And that those same people that are saying, oh yeah, we want privatization, can be affected by it. So again, we have to keep sounding the alarm bell to say, no, this is not what we want whatsoever here.
Well, two heartbreaking scenarios that aren't in the book. When I was just doing research for the book, I was reading about a young lady who had health insurance. She had health insurance. Her deductible was $7,000. So she got sick the latter part of a year, the fall of a year. She had to put $7,000 on her credit card to activate the insurance. The following year, her treatment was not finished. She got sick again. They wanted another $7,000, which she put on her credit card to start treatment again. Now, remember, this is somebody carrying insurance. At the end of the day, mid-chemo, she had to leave the chemotherapy and go back to work because she was accruing this insurmountable amount of debt. This is somebody with insurance. Another article that just broke my heart was a 9-year-old girl, I believe this was in California, had set up a lemonade stand, and her parents had insurance, but they were $10,000 or $15,000 short of the money they needed for the mother's brain surgery because the mother had this huge brain tumor. So this little girl had set up a lemonade stand in her neighborhood. And it made me think of when I was 9 years old. I don't know what all your listeners were doing, but I was running around in industrial Cape Breton, riding my bike, picking blueberries, hanging out with my friends, playing with dolls. One thing I wasn't doing was laying awake at night wondering what I can do to get some money because my mother needs brain surgery and there's nobody to pay for it. And so when we talk about the history of Medicare, this is what Tommy Douglas and his cohort did. So we would never have to be in that position. And if we don't wage this war against privatization, we will be there quicker than you think.
I believe it, Cathy. And again, this is why we're having this conversation today. So your book does serve as a call to arms for average Canadians, for Canadians across the board. And, beyond voting, what are 1 to 2 of the most implementable solutions that you can think that citizens can immediately do to have some form of healthcare activism to combat the political and corporate forces that are pushing privatization forward?
So there are lots of us out there. There is a group called Doctors for Medicare. There are all the health coalitions and then the Canadian Health Coalition. People can join their health coalition. People can read the health coalition information. People can get together and in my opinion, the only thing that really changes policies like this are people on the ground, are grassroots movements. If you look at the suffragettes, if you look at the liberty movement, if you look at civil rights, it all starts with people on the ground. It doesn't start up here. The other thing I would say people can do is when you read this privatization, the proponents of privatization and what they're saying, like, for example, the Fraser Institute, if you look at some of their articles, follow the money. Who is benefiting from this? Is it a big corporation like, now? We have a couple of private clinics in Canada. I think there's 3 where you get paid to give your blood. So we're now in the blood selling business. There's about 600 of those clinics in the States. And until about a decade or so ago, we have fended them off. But there's this big multinational pharma organization that's selling blood products and plasma. And so now we are starting to see that burgeon throughout the country. But follow the money trail and do your research. The research is there. A lot of what they're saying is just not accurate. The evidence is there. You just have to look for it.
No, I think you're completely right. And I think that even finding those grassroots organizations, like I'll post all the links to Canada Health Coalition as well as Ontario Health Coalition.
Yeah.
I believe they're actually going to be doing a march sometime soon. Actually, I believe it's like the 29th. But yeah, like I think it's so important that we know of those grassroots organizations that's doing this work, because I do feel that I also get people that they have this sense of helplessness. Like, what can I do? Like, I'm just one person. It's just like, you would be surprised at what you can do. And again, that advocacy looks different for everyone. For some people, they want to march, but some people want to write a letter. That's still fine. But just knowing where to get that, where to leverage that support, or where you can put, lend, whether it's your dollars, your time, or your efforts to, I think it's so important that we know where those places are. So thank you for those recommendations. Is there anything that we haven't touched on that you'd like to touch on before we go?
I guess I'd like to say to listeners that I am really, really concerned about what's happening in the healthcare system. I think that, in a sense, as my book articulates, it's a bit of a deliberate disintegration. If you listen to some of the great philosophers of our time, like Noam Chomsky or Hedges or Howard Zinn, they say there's sort of a prototype for privatizing public services, and it goes like this. You let the public system fall apart like we feel our governments have done with healthcare, because, as you know, we've been crying since the 90s. We're not going to have enough nurses. We're not going to have enough doctors. We're not going to have enough hospital beds. And really, that's been falling on deaf ears. So there is this prototype that says that governments let the system fall apart, and then when it's totally disintegrated, they rush in with the rescue, and the rescue is privatization.
Right.
But the other end of that is that often does not turn out very well, certainly for consumers, because things get privatized, costs continue to escalate, healthcare outcomes decline, and then at the end of the day, the government, it goes full circle, ends up bailing out the privatized entities. So
Yeah.
Noam Chomsky and those guys would say, this is what Thatcher did in the UK in the 80s. And this is what's happening to a lot, not just health, but a lot of our public services right at the moment. But for us and for nurses, we know how crucial. It's one thing to accrue debt and lose money. I guess in my mind, I feel there'll always be some way out of that. But for me, losing the public healthcare system is losing our Canadian identity.
I agree.
And we see what's going on elsewhere and south of the border. And now is the time for Canadians to step up to the plate and say, no, we are Canada. We are not going there. We're not going to be on this hyper consumption train. We're not going to get involved with big insurers, and we're not going to pick and choose who we care for. We're going to look after the sickest people, irrespective of how much money they have.
Yeah. I think that, you know what you said there, I think is so important. And I think that many people will take that message away and say, yes, what else can I do? How else can I be a part of it? Because I agree 100% with you. I think that, I think we should use that as a strength as Canadians, that's what really defines us, that we do see
Absolutely.
care before profits, right? It's people before profits. And I know that there's a lot of people out there that agree with us, that echo those sentiments, but we need to put a reality check for some of those folks that are really trying to say that, maybe this would be the solution, knowing that it would not be. So again, thank you, Cathy, so much for coming on the Green Nurse podcast. Where can people find your book?
So my book is at Amazon.ca. It's in most Canadian bookstores. Chapters usually carries it. A Chapters in your area. If not, you can order it through Chapters. If you're handy your Indigo Chapters bookstore, they will order it and you can pick it up. There'll be no delivery charge, of course, but it is on Amazon.ca. And I just want to add, in the book is a list of things of organizations and things that average citizens can do, and that includes looking into bloodwatch.org, who is an organization that's very concerned about this privatization of plasma clinics, and then all the others that we mentioned. So there is a list there in the book somewhere.
No, thank you for that, and I'll add whatever resources and links I can at the end of the episode as well. Where can people find you, Cathy? Do you have social media?
So I'm on social media. I'm on Facebook. I'm on LinkedIn, and I do have my webpage, www.dyingtobeseen.ca. So you can email me directly through there. Love to hear from people who have read the book. Welcome all input, good and bad.
Yes, no, it was an amazing book. Thank you for putting it on my radar as well. And thank you so much for coming on the Green Nurse podcast. I'm sure we have to meet sometimes. I was in Nova Scotia and we should have connected somehow, but maybe, if you come back to the GTA or I come back up there, we can have a little bit of a connection, because I feel that there's some work to be done.
Yes, there is some work to be done. And I feel that we are kindred spirits.
I agree.
So absolutely, if you're ever in Nova Scotia, you'll have to let me know. And certainly if I'm in GTA, I will let you know beforehand.
All right. Thanks so much for coming on to the Green Nurse podcast, and I'm sure we'll be connected.
It was my absolute privilege.
Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much, and stay tuned until next time. Stay gritty.